Okay, so we'll be discussing hypertension today and antihypertensive medications. We'll be talking about hypertension. We'll define what hypertension is. We'll describe the risk factors for hypertension. And we'll talk about the main classes of drugs and how those main classes of drugs work, and also special side effects associated with those medications. Then we'll be talking about the pharmacological treatment of hypertension based on the JNC7 report. And that is the latest report out for the treatment of hypertension. And this presentation is based off of, well, the majority of this presentation is based off of the JNC7 report, which is the Joint National Committee on the Treatment and Prevention of Hypertension. And they have reclassified blood pressure, reclassified hypertension. The old 120 over 80 is actually considered pre-hypertensive. So they want it less than 120 over 80. So again, 120 over 80 is considered pre-hypertensive. Then we break that down into stage 1 and stage 2. The reason this is important, you'll see later on, is how many medications do we put the patient on. With stage 1, they get one medication, or they start the patient out on one medication. If it's stage 2, we start the patient out on 2 medications. And again, all this is according to the JNC7 report. 2 types of hypertension. First is primary, and this is simply idiopathic hypertension. We don't know why you have high blood pressure, you just do. And about 90 to 95% of all of your patients will have primary hypertension, simply unknown cause. We don't know why you have high blood pressure, you just do. Then we have secondary hypertension, and this is due to a specific cause, to where we can go, you have high blood pressure because of X, and we can define what X is, and hopefully treat that, or at least know what is causing it. And about 5 to 10% of your patients will have secondary hypertension. So what's the big deal about high blood pressure? Why should we even be concerned about it? Well, the relationship between blood pressure and cardiovascular disease is positive and continuous. So what this simply means is, as our blood pressure goes up, the risk for cardiovascular disease goes up. It's also known as the silent killer. Oftentimes, no really signs and symptoms with hypertension. If a patient has a lower respiratory tract or upper respiratory tract infection, they're going to be sick, they're going to feel sick, they're going to have a fever, they're going to have perhaps a cough, chills, all the good stuff. If a patient has high blood pressure, they're not going to have a fever. They're not going to have this sort of feeling of very lethargic, very tired, very sick feeling. They're not going to have that with hypertension. And we want to prevent such things as stroke, heart attacks, renal damage, retinopathy. The number one preventable risk factor for stroke is hypertension. The number one preventable risk factor for stroke is hypertension. This is the reason it's so important. There's no reason it should be number one. We've got great drugs on the market, lots of different drugs on the market, so if one drug doesn't work or we have side effects, try something else. But again, patients have blinders on. They don't realize the importance of high blood pressure. So if a patient comes to diagnose them with high blood pressure, hypertension, and you put them on a medication, they go to the pharmacy, they pay 20, 30, 40, 50, 100 bucks for the prescription when they don't have any signs or symptoms of high blood pressure. So then they pay the money, they go home, they start taking the medication, they become very tired, very lethargic. They may develop some of the more serious side effects, such as a cough or peripheral edema. They simply quit taking the medication. They don't realize how important it is. And they also don't realize that we have other medications we could try the patient on. So it's very important to counsel the patients. Again, the patients have the blinders on. they don't realize the importance or significance simply of high blood pressure, and that's very important to counsel the patient on. This is not a picture of my ex-wife, by the way. I'll show you a picture of her in a later presentation. However, this is my ex-mother-in-law, so I think you can see the, you'll notice the resemblance later when I show you the picture of my ex-wife. Risk factors. Now again, this is defined by the JNC7 report. So risk factors for hypertension is going to be obesity, excessive sodium intake, excessive alcohol, lack of exercise, and family history. The one that we cannot change, unfortunately, is going to be family history. We would like to change our genetics sometimes, but unfortunately we cannot. So family history cannot be changed. If a patient has a history of hypertension, good chance they will have hypertension. These are the things we can control. Before I go over the slide, let me emphasize this point. The first line of therapy for hypertension is lifestyle modifications. Lifestyle modifications, then we add drugs. The number one, if it's pre-hypertensive, if it's stage 1, if it's stage 2, first thing is going to be lifestyle modifications, then drugs. What are the lifestyle modifications? Well, it's really the opposite of risk factors. So weight reduction, the DASH diet, lower sodium intake, aerobic exercise, decreased alcohol. So this is again sort of the opposite of the risk factors. And again, this is first line therapy for treatment of hypertension. So we do this as we are before we add the drugs, or as we're adding the drugs. This has to be changed. Now we'll discuss the different classes of medications and a little information about those particular classes. First drug we come to is diuretics, simply also known as water pills, and basically the patient just urinates more. So it works by sodium and water excretion through the kidneys. Use blood pressure control and edema. So patient have pulmonary edema, peripheral edema. Some of the side effects, potentially hypokalemia, fatigue, dizziness, patient become lethargic, tired. That part should wear off. If the patient develops this low potassium, that's not going to wear off. So patient may have to take some potassium supplements depending upon the severity of it. They may simply be able to eat more bananas and drink orange juice to suffice, or may actually have to put the patient on a supplement such as K-Ador. The types of diuretics we'll be looking at are loop diuretics, working in the kidneys and the loop of Henle. So we have furosemide, our potassium-sparing diuretics, such as our triamterene, and then we have our thiazide diuretics, such as hydrochlorothiazide. Next we come to beta blockers. Beta blockers block the sympathetic nervous system, so the fight or flight. The beta blockers block that response. Lots of uses with beta blockers, but the ones that we'll be specifically looking at in this presentation is going to be for blood pressure control, also prolonged survival after MI, and for heart failure. A couple of the side effects to point out with the beta blockers, and it's very important, is one is it can mask hypoglycemia. So a diabetic patient, for example, this will not be a good choice to put on. Also, it can worsen symptoms of asthma, because with beta blockers, depending upon if it's selective or not, because we have beta-1 receptors, which are located in the heart, and we have beta-2 receptors, which are located in the lungs. If we notice the ending on the beta blockers, OL, that's indicative of beta blockers. So the three examples I have up here, there are more, but three examples I have is atenolol, metoprolol, and propranolol, three examples of beta blockers. Next, we come to calcium channel blockers. They are a direct vasodilator, and I want to separate these two and discuss dihydropyridines and non-dihydropyridines. So do not get these confused, and they often are confused. So we sort of have the big category of calcium channel blockers, then we have the subcategory, does this particular drug fall into a dihydropyridine or non-dihydropyridine? The dihydropyridines work more in the peripheral vascular system, so such as nifedipine or amlodipine. Then we have non-dihydropyridines, and this works more in the heart. So patients who have pectoris angina, chest pain, also arrhythmias, you may see on diltiazem or verapamil. A couple of the side effects I want to point out here is that calcium channel blockers can potentially cause this peripheral edema. And if the patient develops the peripheral edema, unfortunately it's not going to go away. So it's not like the patient is tired or lethargic. So hopefully the body will adjust to that. But with the calcium channel blockers, if they develop this peripheral edema, they will have the peripheral edema. We'll have to put the patient on a different medication. So if a patient has hypertension, for example, the dihydropyridine would be a good choice to put the patient on. If the patient had some type of arrhythmia or chest pain, then a non-dihydropyridine would be a good choice to put the patient on. Next we come to ACE inhibitors, which stand for angiotensin converting enzyme. And I'll show you a schematic in just a moment to explain how ACE inhibitors and ARBs work. So with ACE inhibitors, it blocks the conversion of angiotensin I to angiotensin II. As far as the use of the ACE inhibitors, blood pressure control, and also they have a protective effect on the kidney. Oftentimes you'll see a diabetic patient on an ACE inhibitor or a low-dose ACE inhibitor. Some of the side effects potentially is going to be this cough, and even more specifically, it's going to be a dry, hacky cough. And I'll show you the mechanism of that in just a moment. If the patient develops the cough, the closest drug that you could put the patient on that's related to the ACE inhibitors are ARBs, angiotensin II receptor blockers. We'll talk about those in a moment. Some examples of ACE inhibitors, benazepril, lisinopril, and quinapril. Also, I'll mention this potential of hyperkalemia. If the patient has high potassium levels, then ACE inhibitors is not a good choice to put the patient on. Now let's discuss ARBs, and then I'll show you the schematic to explain how ACE inhibitors and ARBs work. So let's say, for example, you put the patient on an ACE inhibitor, and they develop this dry, hacky cough. So the closest thing you put the patient on is an ARB, which stands for angiotensin II receptor blocker, and it blocks angiotensin II at the receptors. And I'll show you that in the schematic. Same uses as with ACE inhibitors, and it's often substituted when patient cannot tolerate the ACE inhibitors due to the cough. Some examples is the Cozar, Diovan, Mycardis. Now, let me pull up the chart to show you the schematic. It may be a little confusing and also maybe a little difficult to see on the video. But what happens is we have angiotensin I, maybe better. We have angiotensin I, and that is converted to angiotensin II. And then we have sort of this cascade or domino effect that happens, which ultimately leads to high blood pressure. We have increased sodium reabsorption, increased antidiuretic hormone, increased vasoconstriction. All this stuff happens, which is going to increase blood pressure. So when we take an ACE inhibitor, we block the pathway here, so all of that then goes away and the patient does not develop high blood pressure, hypertension. But what happens with our ACE inhibitors, when we block here, we're also blocking this pathway here. And this pathway blocks that bradykinin, which is what is responsible for cough. So if the patient develops that cough, you can put the patient on an ARB, which is an angiotensin II receptor blocker. Now, if you put the patient on an ARB, it's going to block it, but further down the chain. It's going to block it here. So again, we go from angiotensin I to angiotensin II, and then with our ARB, we stop it here, so then all this goes away. By doing that, we're also blocking it further down the chain, bypassing this bradykinin pathway. So we do not develop that dry, hacky cough with our ARBs.